Most people believe that if a surgeon recommends an operation, it must be the right call. The doctor knows best. The hospital has the equipment. The consent form is already printed. Just sign here. I used to accept that too, until I started counting the patients who went in for a routine procedure and came out permanently different. Not better. Different. A man who walked into the hospital with back pain and never walked normally again. A woman who survived a major operation but lost half a year of her life to complications nobody sat her down and warned her about. Here's the sentence I want you to remember for the next 25 minutes. The older your body is, the harder it has to fight just to survive the operation itself. Separate from whatever the operation is trying to fix. I'm Dr. Claire Brooks. I've spent close to 2 decades practicing internal medicine, sitting across from patients right before and right after they make some of the biggest decisions of their lives, and walking alongside surgical teams through more of these conversations than I can count. Today, I'm going to walk you through 5 surgeries that carry serious, under-discussed risks for people over $60, and exactly what to ask before you ever let anyone near you with a scalpel. Let me ask you something first. If you put a brand new car and a car with 200,000 miles on it through the exact same stress test, do you expect the same outcome? Of course not. And yet for decades, medicine has treated a 70-year-old body almost exactly the way it treats a 40-year-old one. Same protocols, same recovery timelines, same expectations. That is finally starting to change, not fast enough. What surgery actually does to an older body? Here's what happens inside an aging body under general anesthesia. And once you understand this, everything else in this video is going to click into place. The heart has to work harder to compensate. The lungs take longer to clear anesthetic gases out of the system. The kidneys slow down processing every medication you're given. And the brain, this is the part that catches people off guard, can become disoriented in ways that last weeks, sometimes months. There's a real medical term for it: post-operative cognitive dysfunction. In patients over 70, it happens far more often than most families are ever told to expect. Now, I want to be completely clear about something before I go any further. Age by itself is not a reason to avoid surgery. I've watched 80-year-olds bounce back faster than some 50-year-olds. Age is just a number. Frailty is not. Frailty is an actual medical measurement. It means your body's physical reserve has dropped below a critical threshold. Roughly 4 in 10 people over 75 show measurable signs of frailty. Past 85, that climbs towards 6 in 10. So here's the real question nobody's asking in that consultation room. It's not, can this person survive the operation? It's, can this person survive the recovery? Those are 2 completely different questions, and that distinction is about to matter for every single item on this list. Surgery 1. Open heart surgery in a frail body coronary artery bypass grafting, CABGE, is one of the most common major operations performed on older adults. The concept is simple. Your arteries are blocked, so we build a detour around the blockage. Done in the right patient, it works beautifully. Here's what the consent form doesn't spell out for you. Traditional open heart surgery requires stopping your heart completely and putting you on a bypass machine, a device that takes over for your heart and lungs while surgeons work. In a fit 60-year-old, that's a manageable ordeal. In a 78-year-old with kidney disease, mild diabetes, and early cognitive changes, that bypass machine is putting every organ system in the body under simultaneous strain. In frail elderly patients, this kind of surgery carries roughly a 30 to 40% risk of a major complication: stroke, kidney failure, prolonged confusion, extended time on a ventilator. And here's the number that stops people cold. In the highest risk elderly patients, up to 15% do not survive the first 30 days. So what's the alternative? Often today there is a catheter-based procedure called TAVR that reopens or replaces the valve without ever stopping the heart or opening the chest. Far less dramatic, far kinder to a body that needs gentleness, not a battle. Does that mean refuse heart surgery? Absolutely not. It means walk into that consultation and ask one specific question. Am I a candidate for a less invasive approach? That single sentence can change the entire trajectory of your recovery. Surgery 2. Aggressive spinal fusion. Back pain past 60 is close to universal. I don't think I have a single patient over 70 who hasn't brought it up. And the solution offered more and more often is spinal surgery, fusions, multi level decompressions, hardware running up and down the spine. I need you to hear this clearly. Some spinal surgeries are genuinely urgent and necessary. Active spinal cord compression, sudden loss of bladder control, progressing paralysis, that needs a surgeon immediately, no debate. But elective fusion for chronic degenerative back pain in an older patient is a different story, and the evidence here is genuinely troubling. Research on patients over 65 undergoing complex spinal fusion has found complication rates exceeding 40% to yours, and these aren't minor complications. Blood clots, infections, hardware failure, and something surgeons call adjacent segment disease, where the vertebrae just above and below the fused section start breaking down because the fusion locks one part of the spine rigid and the rest of the spine absorbs the cost. Here's what frustrates me most. For a lot of elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than physical therapy combined with targeted injections. No better outcome, with dramatically higher risk. A colleague of mine, a genuinely brilliant spine surgeon, once told me, "Claire, sometimes the best operation is the one you don't do." I think about that sentence constantly. Have you ever been told surgery was your only option for chronic back pain? Tell me in the comments. I want to know how many of you have heard that exact phrase. Surgery 3. Major cancer resections. This is the hardest one to talk about because the moment someone hears the word cancer, the instinct is immediate. Cut it out. Get it out now. I understand that instinct completely. I'd feel it too. But here's what 2 decades of medicine have taught me. The goal was never simply remove the tumor. The goal is more good years of life. And sometimes, not always, but sometimes, major surgery in a frail older patient works against that exact goal. Take the Whipple procedure for pancreatic cancer, one of the most complex operations in all of medicine, removing part of the pancreas, part of the small intestine, the gallbladder, and part of the bile duct in an operation that can run 6 to 10 hours. In a healthy younger patient, it can be genuinely life-saving. In an 80-year-old with heart disease and reduced kidney function, the surgery can technically succeed, the tumor is gone, and the patient can still pass away weeks later from surgical complications, not from the cancer, from the operation itself. There's a term for this: failure to rescue. Research from major surgical databases has found that close to 1 in 5 elderly cancer patients undergoing major resection experiences a complication their weakened body simply cannot recover from. So, what's the question worth asking your oncologist directly? If we don't operate, what does watchful waiting, radiation, or targeted therapy realistically look like for someone my age and health profile? That question opens a door a lot of patients never even knew existed, and sometimes what's behind that door is genuinely the better path. Surgery 4. Elective joint replacement in a fragile body. Hip and knee replacements are among the most successful surgeries ever developed. I say that with zero hesitation. For the right patient, a new hip is transformative. People go from barely walking to chasing grandchildren around a backyard. But here's where it gets complicated for older adults. The word elective means you have time. Time to think, time to prepare, time to ask whether right now is genuinely the right moment for your specific body. Because the data is clear. In patients over 75 carrying 3 or more serious conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries meaningfully elevated risk. Blood clots are the biggest danger. Deep vein thrombosis in the legs that can travel to the lungs and become a life-threatening pulmonary embolism. In patients with reduced circulation, that risk climbs substantially. Add in post-operative pneumonia from extended time immobile, add hospital-acquired infections, and the picture gets complicated fast. I want to be precise here because I don't want to scare anyone away from a surgery that could genuinely change their life. The question isn't, should I ever have this done? The question is my body in the best condition it can be right now? Optimizing blood pressure, blood sugar, weight, and cardiovascular fitness before an elective surgery can meaningfully lower complication rates. Some hospitals now require a formal prehabilitation program before scheduling these operations for higher risk older patients, and that is exactly the right approach. Has your doctor ever brought up prehabilitation before a planned surgery? Most people have never even heard the word. You should have. Surgery 5, emergency abdominal surgery. This one is different from the rest, and it belongs on this list for a different reason. You don't choose emergency surgery. It chooses you. A perforated bowel, a ruptured appendix, sudden internal bleeding. These situations do not wait for a calm conversation in an office. But knowing the risks before the emergency happens changes how families make decisions in those terrifying middle of the night moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. In the most severe cases, we're talking 30 to 50%. Not because surgeons lack skill, but because an older body under sudden trauma is fighting on too many fronts simultaneously. Liver, kidneys, heart, lungs, all hit at once. And an inflammatory response a younger body would control within days can spiral in an older body into something called systemic inflammatory response syndrome, multiple organs beginning to shut down in sequence. It is exactly as serious as it sounds. So, what do you actually do with this? Two things. First, don't ignore abdominal symptoms. Persistent pain, bloating, or changes in bowel habits in anyone over 60 deserve prompt medical attention. Catching a problem early means treating it before it becomes a 2 a.m. emergency. That one habit alone can change everything. Second, have the conversation with your family now, not in a hospital hallway at midnight. What are your wishes if emergency surgery becomes the only option? What quality of life actually matters to you? These conversations are not morbid. They are one of the most loving things you will ever do for the people who might one day be standing in that corridor. The 4 questions every patient over 60 should ask. We've covered 5 surgeries. Now let's talk about what you actually do with all of this. Because information without action is just anxiety, and that is the last thing I want to leave you with. Before any major surgery, planned or recommended, write these 4 questions down and bring them with you. Question 1. What happens if I don't have this surgery? A good surgeon will give you a direct answer. If nothing urgent changes over the next 6 to 12 months, you have time to think, time to get a second opinion, time to get your body into better shape first. Question 2. Is there a less invasive alternative? Medicine has changed enormously in the last 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions, options that simply didn't exist a decade ago are now standard at most major hospitals. Question 3. What does recovery realistically look like for someone my age and my exact health profile? Not the average patient. You. Your heart, your kidneys, your medications, your living situation. The answer should be specific to you, not a generic pamphlet. Question 4, the one almost nobody asks. What is your personal complication rate for this exact procedure in patients over 70? Surgeons track this. They know their numbers. A confident, honest surgeon will tell you plainly. If they get uncomfortable at the question, that discomfort is information too. This isn't a video about fear. It's about options. Before I get to the most important part of today, I want to leave you with something genuinely hopeful, because that's the truth of where medicine stands right now. Minimally invasive surgery has transformed what's possible for older patients. Laparoscopic procedures with small, camera-guided incisions dramatically shorten recovery. Robotic-assisted surgery brings a level of precision human hands alone can't match. Catheter-based cardiac interventions have opened doors for patients who never would have survived traditional open surgery a generation ago. And beyond surgery entirely, this is something I wish more patients heard, optimized medical management is genuinely powerful. The right combination of medications, supervised physical therapy, Targeted injections and nutritional support can manage conditions that used to seem to demand a scalpel by default. The body wants to heal. Sometimes our entire job as physicians is simply to get out of its way and hand it the right tools. Meet Walter. I want to tell you about a patient I'll call Walter, 71, retired engineer, still sharp as anyone I know. He came to me after three separate surgeons had all recommended open heart surgery for a blocked coronary artery. Three surgeons, three identical recommendations. Walter wasn't afraid of surgery. He was afraid of losing himself. He'd watched his wife go through a major operation 2 years earlier and come out of it confused, exhausted, and never quite the same person she'd been before. He told me, "Dr. Brooks, she went in as my wife and came out as someone I had to take care of." That sentence has never left me. When I went through Walter's full picture, his kidney function, his frailty score, his cognitive baseline, I sat down with him for 40 minutes, not the usual 15, and told him the truth. Surgery was one path. So was an aggressive medication protocol paired with structured cardiac rehabilitation. For his specific profile, the data showed comparable 5-year outcomes between the two approaches. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photo, standing at the top of a hiking trail in Colorado, flanked by two granddaughters now taller than he is, grinning like he'd just won something. Here is the single most important thing I will say to you today. A surgical recommendation is not a verdict. It is the opening of a conversation. You are not a passive recipient of what happens to your own body. You are an active participant in your own care. The moment you sit down in a surgeon's office, you have the right to ask every hard question, request every alternative, and take every day you need before deciding. The surgeon holds the scalpel. You hold the choice. And a choice made with full information, in clear eyes, is the single most powerful tool in medicine, more powerful than any operation I have ever assisted or witnessed. Bringing it all together, 5 surgeries that carry serious, under-discussed risk for people over 60. 1. Open heart surgery in frail patients where less invasive alternatives increasingly exist. 2. Aggressive spinal fusion where the evidence for lasting pain relief is far weaker than most patients are told. 3. Major cancer resections where the true goal must always be more good years of life, not just tumor removal. 4. Elective joint replacement in a fragile body, where timing and preparation matter nearly as much as the surgery itself. 5. Emergency abdominal surgery, where your best protection is catching problems early and having honest family conversations before you ever need to. None of this means avoid all surgery. Surgery saves lives every single day. I've watched it happen, I've been part of it, and I remain proud of that work. The message is simpler than that. Be an informed patient. Ask the hard questions, request the alternatives, get a second opinion, a third if you need it. Your age is not a weakness, but it is information, and you deserve a medical team that treats it that way. What's the one question you'd most want to ask your surgeon before a major operation? Put it in the comments. I read every single one. And if this video helped you or someone you love think more clearly about a surgical decision sitting in front of them right now, share it with them today. Not next week, today. That one share might end up being the most important thing you do all week. Subscribe if you want more of these plain-spoken, no-fluff conversations about how to actually protect your health as you get older. This channel exists for exactly this. Take care of yourselves. Stay curious. Keep advocating for your own care. You deserve a physician who explains everything and a medical team that treats you as a partner in the decision, not just a patient signing a form. One last thing, because it matters. Everything in this video is general medical information based on published research and clinical experience. Every person's situation is different. Before making any decision about surgery or treatment, have a full, honest conversation with your own doctor or specialist. They know your history, your body, and your specific risks in a way no video ever can. That unhurried conversation is exactly where good medicine actually begins. I'm Dr. Claire Brooks. I'll see you in the next one.